Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. For every clinician dealing with abdominal imaging, surgeons, gastroenterologists, radiologists, we've all had that moment.
Oh, yeah.
An incidental pancreatic cyst just pops up on a scan, and right away you're thrown into this high-stakes game of clinical triage.
It happens all the time.
Are we looking at something totally benign that you can just watch, or is this one of that small, silent minority that's harboring high-grade dysplasia or even invasive cancer?
And that's really the whole challenge, trying to tell the difference.
Which is why we're here today.
Exactly. Our mission is to give you the most efficient shortcut we can, synthesizing the core ideas from the Fukuoka, the ACR, ACG, and the European guidelines.
We need to unpack the thresholds for risk, for surveillance, and really, what are the specific features that tell you this patient needs surgery now versus this patient can safely go into an MRI surveillance program?
Yep. But before we get into the critical numbers, we have to the mandatory reminder. This content is for reference only. It's a synthesis of the literature. As clinicians, you must always follow your local guidelines and your institutional protocols.
Okay, let's jump in. To really unpack this, we first have to identify the main culprits. When we talk about these cysts with real malignant potential, which ones are we really focused on?
You have to focus on the two main mucin-producing players. That's the intraductal papillary mucinous neoplasms, or IPMNs, and the mucinous cystic neoplasms, MCNs.
But even within those categories, the risk is, it's dramatically different.
It really is. A stable branch duct IPMN versus a main duct IPMN. It's like you're talking about two completely different diseases.
The main duct involvement, that's everything, isn't it?
It's the key driver of risk. An MD-IPMN is often considered, a cancer in waiting. Your malignancy risk can approach 60, even 70%.
Wow.
Whereas a small, stable branch duct IPMN, you're often looking at a long-term risk that's below 5%. So that distinction, main duct versus branch duct, is foundational.
And we know there are other types like serous cystadenomas, which are much lower risk, but it's this hunt for the high-risk IPMN or MCN that drives these really rigid surveillance protocols.
Exactly. The whole goal is simple, but the execution is tough. You want to find that small subset with high-grade dysplasia or cancer early enough that you can do a curative resection.
You're looking for that sweet spot, not overtreating the benign ones, but not missing the one that's about to become a tragedy.
That's the game.
So this brings us right to the core triage mechanism and pretty much all the guidelines. They all seem to converge on these two categories: high-risk stigmata versus worrisome features.
Right, and you could think of them as two different traffic lights. High-risk stigmata, or HFS, that's a red light.
Meaning stop, go directly to the OR.
Well, it correlates so strongly with cancer that in a fit patient, it immediately triggers a discussion about resection. Worrisome features, on the other hand, that's your yellow light.
So slow down, get more information.
Precisely. It triggers an immediate escalation to EUS for a much closer look.
Okay, let's nail down that red light then. High-risk stigmata. What are the urgent triggers we need to have memorized?
There are four main ones. Number one is obstructive jaundice that you can clearly attribute to the cyst, especially if it's in the head of the pancreas.
Okay, that makes sense. It means it's big enough to be causing a real problem.
It often signifies invasive growth blocking the bile duct.
And what about the imaging metrics? I know there are some very specific numbers.
There are. Number two is the presence of an enhancing mural nodule, or a solid component that is 5 millimeters or larger, or just an unequivocal solid mass.
Why 5 millimeters? That feels so specific. Is that just based on strong data?
It's entirely pathology-driven. The data shows that a nodule of that size has a significantly higher chance of being high-grade dysplasia or frank cancer compared to smaller nodules.
So if you see 5 millimeters, you have to assume the worst until you prove otherwise.
You have to. Number three is about the main pancreatic duct, the MPD. Specifically, a dilation of 10 millimeters or more.
And that takes us back to what you said earlier about main duct involvement being the real danger zone.
Exactly. Once it hits 10 millimeters, that's the clearest sign of a high-risk main duct IPMN that needs to come out.
It's amazing that the difference between, say, 9 millimeters and 10 millimeters can be the difference between EUS and surgery.
It's a seismic shift in the patient's risk profile. And finally, number four is the definitive one. Positive cytology for high-grade dysplasia or carcinoma from an EUS FNA.
The pathological proof.
The proof.
All right, now for the yellow light. Worrisome features. These don't send you straight to surgery, but they demand that immediate next step. What are the main WF triggers?
First off, size itself. A cyst that's 3 centimeters or larger is generally considered worrisome.
And that's the trigger for EUS, even if nothing else is wrong.
Right. Now, some guidelines will use 4 centimeters as a relative indication for surgery, but 3 centimeters gets you the EUS.
Okay, what's next?
Second is the smaller scale duct dilation. So an MPD is between 5 and 9 millimeters, or an abrupt change in the duct's caliber with some downstream atrophy.
Got it. And what about nodules?
A smaller enhancing mural nodule, so one that's less than 5 millimeters, or just a thickened enhancing cyst wall. Even if it's small, it's enough to warrant that EUS.
I think the one that's hardest to track sometimes is growth. What's the definition of rapid growth here?
That is a major red flag. We're looking for interval growth of 5 millimeters or more over 2 years, or just 5 millimeters in a single year.
So if you see that kind of growth, the whole wait-and-see approach is off the table.
Immediately, you trigger the EUS.
And we can't forget the clinical picture, the systemic cues.
Absolutely. The biochemical markers are key. An elevated serum CA, 19 to 9, say over 37, without another cause, is a worrisome feature.
And what about symptoms?
Any pancreatitis that you can attribute to the cyst, or even new onset diabetes or diabetes that's suddenly gotten a lot worse in the last year, all of those are significant.
That's a fantastic framework. Let's shift focus now to the frontline clinician, the GP or the general surgeon who sees the initial scan. What are the most practical red flags for them that should trigger an urgent HPB referral?
That's a great way to frame it. I think the key is recognizing that a combination of things can equal urgency.
Right. It's not just about one number hitting a threshold.
Exactly. First, if the patient is symptomatic, we're talking obstructive jaundice, unexplained weight loss, new diabetes, or pancreatitis, the referral should be immediate. Don't wait.
Don't wait for the imaging to be perfect.
Don't wait. Then on imaging, if you spot any mural nodule, an MPD of 5 millimeters or more, or a cyst that's 3 centimeters or bigger, that should also trigger an immediate referral for an MD2 review.
The takeaway for anyone seeing these scans first seems pretty clear.
I think so.
If you have a patient who's fit for surgery and they have any of these red flags, your bias should be towards aggressive workup, not passive surveillance.
I agree completely. Better to over-refer for evaluation than to miss that window for a cure.
Okay, so once we've triaged out the patients who need urgent surgery, we're left with surveillance. Who are we watching and how are we watching them? And maybe just as important, who should we not be watching?
That's a critical question. We should only put patients into long-term surveillance if they're actually fit for surgery and have a reasonable life expectancy.
Because if they couldn't survive a Whipple,
Then what's the point of the scans? The findings wouldn't change your management, so you stop.
makes sense. And for modality, I'm assuming we're trying to avoid radiation.
Absolutely. MRI and MRCP are the preferred tools for follow-up. You avoid radiation, and they give you much better detail on the duct-cyst relationship, which is everything for IPMNs.
So EUS isn't the primary surveillance tool.
No, it's a problem-solving tool.
Yeah.
Use it when you see worrisome features on the MRI or when you need to get fluid for analysis.
Let's break down the surveillance intervals based on size.
Hmm.
For a stable, benign-looking cyst with no worrisome features, how often are we scanning?
It's all about the size. For the smallest ones, less than, say, 1.5 to 2 centimeters, you'd start with an MRI in 1 year. If it's stable, you can really space it out maybe every 2 to 3 years.
And as the size goes up, the interval gets shorter.
Correct. For cysts between 1.5 and 2.9 centimeters, you tighten it up. An MRI every 6 to 12 months for the first couple of years. If it stays stable, you can then switch to annually.
Okay, what about when we hit that 3-centimeter mark?
Once you're in the 3 to 3.9 centimeter range, it gets much more aggressive. You're looking at an MRI or EUS every 6 months for a year or two. And in a young, fit patient with a cyst this size, you're already having a serious conversation about resection.
And at 4 centimeters or more?
That size often pushes you into a relative or even absolute indication for surgery. It demands an MDT review. And at every single follow-up, you have to document the growth rate.
Because that 5 millimeter per year growth is an automatic trigger.
It's an automatic trigger for EUS and an MDT review, regardless of the starting size.
This brings us to the escalation path, the EUS. When do we actually pull the trigger and order one?
EUS is mandatory when a worrisome feature pops up. The number one reason is still the mural nodule. If you see any mural nodule or solid component, you need an EUS to confirm its size and get fluid.
And you also use it to clarify the ductal anatomy if the MRI wasn't totally clear.
Yes, if the MPD is between 5 and 9 millimeters, or if the connection between the cyst and duct is ambiguous, EUS gives you that high-resolution picture you need.
And what about size alone?
Any cyst that's 3 centimeters or larger, particularly in a younger patient, warrants an EUS. The goal is to get definitive data. Is this a serious lesion we can relax about, or a mucinous one we need to watch like a hawk?
We often talk about cytology as the gold standard, but we all know how often an EUS FNA comes back non-diagnostic. How much do you rely on that fluid analysis?
That's a crucial point. The imaging metrics, the HFS and WF, are still paramount, but the fluid analysis can be invaluable. A high CEA level can confirm it's mucinous. Cytology tells you the grade. But when it's non-diagnostic, which happens a lot,
You fall back on the imaging.
you fall back hard on the imaging features. That's why those thresholds are so robust across all the guidelines.
Okay, let's just summarize the surgical indications one more time. We have the absolute clear-cut ones.
Right. The patient is heading for the OR if they have obstructive jaundice, an enhancing nodule of 5 millimeters or more, an MPD of 10 millimeters or more, or cytology showing high-grade dysplasia or cancer.
And then there's the gray area, the relative indications.
This is the more challenging group. These are patients with worrisome features. So an MPD in the 5 to 9.9 millimeter range, a cyst that's 40 millimeters or bigger, a small enhancing nodule, or rapid growth.
So if you have a healthy 62-year-old with a 4.5 centimeter branch duct IPMN, no nodule, but they've had a couple episodes of pancreatitis from it. That's a perfect example.
Exactly. That scenario is the definition of a relative indication, and that's where the decision has to be made in an HPB multidisciplinary team meeting. The team has to balance the risk of a major operation against the risk of malignancy, and you have to factor in the patient's age, their health, and critically, their own preference.
Okay, final topic, duration. If a patient has a small, stable branch duct IPMN for 7 years, can they ever be discharged from surveillance?
This is maybe the toughest part of IPMN management. For a fit patient with a known IPMN, a lot of the guidelines recommend long-term or even lifelong follow-up.
Lifelong. Why? What's the risk if the original cyst is totally stable?
The risk is something we call field cancerization. Because IPMN is a disease of the ductal lining, the entire pancreas remains at risk. Even if the original cyst never changes, that patient still has a higher risk of developing a brand new cancer somewhere else in the pancreas.
That's sobering.
It is. However, we do allow for stopping surveillance. It's reasonable when the patient is no longer a surgical candidate or when their life expectancy is limited. And for very small, stable cysts in older patients after maybe 5 or 10 years, sometimes the risk of the follow-up outweighs the benefit.
But the key is to document that decision very clearly.
Absolutely. You have to document the rationale, the MDT discussion, and the shared decision-making with the patient. It's about managing their risk for the rest of their life.
This has been a really crucial deep dive. The core takeaway for any clinician listening seems to be that your entire management strategy hinges on applying these specific imaging and lab thresholds correctly.
It really does.
Knowing the difference between 5 and 10 millimeters of MPD dilation or a 3 versus a 4 centimeter cyst, that is everything.
It's what separates worrisome from high risk.
And that idea of field cancerization raises a really interesting final thought for you to consider. Are we ever truly safe from the pancreatic remnant, even after years of successful surveillance for a small, stable cyst? It's a reminder that our job of risk assessment really never ends.
A great point to end on.
If you found the synthesis of critical guidelines helpful, please don't forget to share this deep dive with at least one of your colleagues or friends to help spread the word. And be sure to check out our content on YouTube and our other social media pages for more. Thanks for listening.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.